Hello, and welcome to this Visionix webinar titled Applications and Benefits of Angio OCT in Daily Practice with Visionix Optovue Solix. Optovue was the first company to introduce Angio OCT technology to the market with the AngioView system in 2014. Since then, it has established itself as a leading reference in the field, offering cutting-edge technological products. Today, the forefront of this innovation is represented by Solix. The Optovue Solix is a state-of-the-art full-range OCT and OCT angiography system that provides a multitude of imaging options, enhanced metrics, and an integrated fundus camera. Key features include high-speed scanning at 120,000 A-scan per second for improved data acquisition, AngioAnalytics OCTA metrics for visualization and quantification of retinal vasculature, DualTrac Motion Correction technology for true 3D motion correction. Precise corneal measurements include full corneal topography for contact lens fitting and refractive surgery planning. Fundus photography. Our webinar speaker is Dr. Paolo Milani, an ophthalmologist with extensive experience in the field. Dr. Milani is affiliated with the I.R.C.C.S. Istituto Auxologico Italiano in Milan, Italy, and has contributed to numerous publications in ophthalmology. Dr. Milani will guide us through the exclusive feature of the Solix system and present several compelling clinical cases. During the webinar, we encourage you to submit your questions using the question mark icon located at the top right of your screen. Alternatively, you can send your inquiries via email to contact@visionix.com at any time. Now I will hand over the presentation to Dr. Milani. Enjoy the webinar.
So, hello everybody, and thanks to Visionix for the kind invitation. I think that the Solix platform is extremely interesting because it uses the OCT technology from the ocular surface deep to the anterior and posterior segment of the eye. In fact, thanks to the full range field of view, a number of clinical applications are possible. Multimodal imaging includes the acquisition of the entire anterior chamber in a single scan and a corneal topography with a precise corneal map. Other than the typical point-by-point pachymetry and epithelial map, which were already provided in the previous release of the device, with Solix we can also have an aberrometry map for the study of the first and second order aberrations. Details of the anterior chamber may be visualized and measured precisely, automatically or manually, such as the depth in the center or in the periphery along with the angle width. A real novelty of the Solix, in my opinion, is the unique and detailed visualization of the crystalline lens. We can explore, in fact, the lens from capsule to capsule, passing through the nucleus and the cortex. Here we can see, for example, a clearly evident anterior cortical cataract, and here is the anterior, and here is the posterior. And we can also highlight any subluxation of the lens, or, as in this case, a very peripheral cortical alteration that can hide some surgical pitfall. Now, I will show you some videos that we were able to obtain using a simple dynamic acquisition software that can be connected easily to the screen of the Solix platform. Here we can see the artificial intraocular lens and the surface of the anterior vitreous. This is the lens, and here is the anterior vitreous. Of course, this is the iris, and up here the cornea. You can also see how thin and opaque the posterior capsule is in this case. Let's see what happens after capsulotomy. Here we can see the edges of the capsule, Here they are. And we can see quite easily the anterior vitreous, which moves here. We can see. So the anterior vitreous can be seen with this bursae and lacunae. So now let's move specifically to the use of OCTA in the posterior segment. Solix provides several acquisition protocols alongside with the classic spectral domain structural acquisition. It aims at an upgrade of 120,000 scans per second and a single scan length up to 16 millimeters. So, classic macular and disc maps may be obtained for the retinal and RNFL thickness investigation and comparison to a normative database. But most of all, Solix avails of the split spectrum amplitude decorrelation angiography technology and many years of experience to provide a detailed study of the macular and optic disc region by means of 3, 6, 9, and 12 millimeters acquisition cubes. I've been using personally the OCT angiography technology for more than 10 years now, and in my opinion, it is not only an academic study interest, but a diagnostic milestone in daily clinical practice. In fact, let's see some examples together. So here we have a multifocal choroiditis in a high myopic eye, and basing on fluorescent angiography only, the presence of a choroidal neovascularization is very uncertain. But on OCTA, the lesion appears clear, either in black and white or in color layout. Another case, in type 1 neovascularization, OCTA may be very useful to identify promptly the neovascular lesion, even in absence of activity, in order to schedule proper controls intervals. In case of idiopathic retinal pigment epithelium detachment, OCTA is essential to exclude the presence of neovascular lesion, as in this case, even if some blood flow may be disclosed in the edge of the detachment, suggesting frequent monitoring of the patient. In central serous-choroidal retinopathy, retinal specialists know that should always seek for neovascular activity, which is usually completely absent, as in this case, but that sometimes can be small and subtle, as we can see here in this other patient. When facing macular spontaneous hemorrhage, like here, OCTA is of the utmost importance to exclude the presence of neovascular lesions, which can be absent at baseline, like here, but that can develop over time, as in this case, where some blood flow can be observed after 10 days of presentation, and that becomes clearly evident after 20 days. OCTA is also essential for monitoring intravitreal therapy efficacy and to check how the lesion responds. This can help greatly to proceed or change the treatment regimen. Here we see the lesion quite big before treatment, then after a couple of intravitreal therapies, and then quite dry here. Particularly interesting is the possibility to obtain video color visualization of the retinal layer investigated. For example, here we have a neovascularization in a high myopic eye, clearly evident on fluorescent angiography and on the outer retina and the choriocapillaris slabs. The typical retinal thickening with RPE elevation and the fuzzy area can be seen on structural OCT, along with some blood flow within the lesion. So, no doubts about the diagnosis. However, the continuous video color mode allows even an improved visualization of the lesion thanks to the color editing of the different retinal layers. In purple, the deep capillary plexus, in yellow the outer retina, in red the choriocapillaris and the choroid. Let's see some cases where the video color can help. Here we have another high myopic eye with a very doubtful neovascularization on structural OCT. The patient reported some recent metamorphopsia and vision loss, and because of fluorescent allergy, an OCTA was performed. The only foveal alteration is the vascular loop, clearly evident on the outer retina segmentation. Even if some blood flow is present within the lesion, are we sure that this is a neovascular lesion and not an abnormal physiological vasculature? Well, the video color highlights even better the localization of the loop, just separated from the surrounding tissue and anterior to a large choroidal vessel. Thus suggesting strongly the neovascular origin of the lesion. In fact, after intravitreal therapy, metamorphopsia reduced, vision gain occurred, and the vascular loop completely disappeared, as can be seen both on static and video color modes. So here before and here after the intravitreal therapy. So now let's move to a young healthy man, completely asymptomatic, but with a very small vascular alteration that can be seen here, close to the fovea, which is visible on the outer retina and in the choriocapillaris. This lesion corresponds to an RPE and outer retina defect with some blood flow within. So, is this a neovascular lesion? Who knows? Well, video color visualization can help, but still doubts remain. Now, let's see what happens 2 weeks later, and we see that now the lesion is much more evident, and even on color code video color, we see that the dimension of the lesion has enlarged. In fact, after the intravitreal therapy, the lesion disappeared completely, both on static and dynamic visualizations. Now, here we have a high myopic patient with some lac cracks that can be seen here, and focal inner retinal detachment. In similar cases, it is essential to exclude the presence of neovascularization and monitor closely the patient. OCTA plays a crucial role, and regardless multiple choriocapillaris and choroidal vascular abnormalities, as we can see here, it does not disclose any neovascular activity. So when moving from the choroid up to the outer retina and the deep capillary plexus, no vascular lesion can be disclosed. Here we have a case of a solid RPE detachment which was previously treated by intravitreal therapy. So in these cases, lesions can be stable for years, but recurrences are possible over time with typical enlargement of both the RPE detachment and the neovascular area, as we can see here. So in similar cases, OCTA proves to be valuable and leads to the prompt and customized retreatment. In fact, here in the outer slab, we can see how the lesion enlarged. And so, very probably it's better to perform a proactive treatment. But also, OCTA can investigate the choriocapillaries and the choroid by detecting the white areas where the flow are present and the dark areas where the flow voids are visible. And this visualization changes as far as we go deeper to the choroid. Also, OCTA can provide vessel density maps of the macula and the disc area. And interesting, it can also measure, tough, questionable, the vessel density of the macular area, and most of all, the density of the choriocapillaries, which, interesting, as we saw in some papers, can be normal regardless the vessel density reduction, which can be typical in glaucomatous eyes. In fact, here we have a typical case with some reduction of the GCC complex that corresponds to a visual defect in the perimetry, but the choriocapillaries remain quite normal. Okay, now let's see some cases live. So here we have an acquisition in AngioView retina protocol 6.4 per 6.4. So if we process the cube, we can see the superficial, deep, the outer retinal slab, the choriocapillaries, and even a customized segmentation that we can move up and down to the inner and outer retinal layers as we prefer. So this case is interesting because there are many drusen and the presence of a neovascular lesion must be excluded in these cases. Here there is some intraretinal fluid, some space, but as far as you can see, no vascular, at least no clear vascular activity can be disclosed in any of the segmentation. Of course, if we check and if we look for the RPE elevation, we can see the map here. And in this case, a color overlay could possibly help because we can orientate beneath the retinal layers, inner and outer layers, but no vascular activity can be clearly seen. We can also see how the lesion behave over time. So here we have the last acquisition on July 2024, but we began 1 year before. So if we check for the multi-scans view, you can see in every slab how the lesion change. And here we can see that at the baseline no fluid was present, but after 7 months some fluid became evident here. But fortunately for the patient, the fluid didn't change over time, at least 1 year after, up to 1 year after. In these cases, we can also check for the vascular density and other interesting parameters, such as the vessel density in the whole image, and then sector by sector. Or, differently, we can check for the foveal avascular zone, which is here, which can be measured in millimeters, in squared millimeters, and also a perimeteral area. And we can also have a selection of the outer or choriocapillaries flow density. Even if the value of this parameter can be questionable, I think that it's interesting in a way, because all these parameters can be studied to understand better the pathophysiology of these lesions. Another interesting upgrading of the Solix platform is the possibility of an accurate and precise reference. In fact, with this new release, this new version, one of the weak points of the previous version is much better improved. For example, here we have an acquisition of a patient of May 2024 and October 2024. We can see how different the acquisition was, because here is the foveal avascular zone, which is not centered in this case. It is in this case, but not in this case. So we can see that the reference alignment is much more precise and almost perfect. We can also check for the superficial and the deep area. We can realign the macular area, and we can see that the lines do correspond, although the investigated areas are not centered. So in this case we can check and we can see any change line by line, scan by scan. And this is very interesting, of course, to see, for example, how the lesion move or respond to the therapy. So, with this new version, the reference is really improved, and I think it's one point in favor of this technology and this software. Now let's see live an acquisition. So right eye, AngioView retina, play. Pushing the joystick, an automatic adjustment starts, and then now we can acquire. So the acquisition is quite simple and fast, non-invasive, and in a few seconds we already have everything. Now the software is working for removing the motion artifacts. We keep the image, the elaboration of the image, and now we see the quality is quite good, 9. The scale is from 0 to 10, sorry. So, Here we have the macular area with all the slabs that we want to see. And if we look to the vessel density, we have a precise map here. So speaking about glaucoma, the Solix platform is interesting because here we can see the RNFL thickness, which is reduced in this patient which has a borderline ocular pressure, and we can see that there is some reduction in the superior part of the peripapillary area, but the study of the vessel density is interesting because we can see that this area of vessel density reduction corresponds to this area and this area of thickness reduction. So in similar patients can be helpful the investigation of the vessel density just to understand and to see before the lesion become evident how can the damage behave at baseline and over time. Just an advice, here the ZCC complex analysis results normal, but the vessel density disclose an abnormality here. Thanks.
We thank Dr. Milani for his excellent presentation. Please remember that you can continue to send your questions to contact@visionix.com, even after the conclusion of this webinar. You will receive an email containing the webinar recording and the link through which you can submit additional questions. Thank you for joining us, and we look forward to welcoming you to the next Visionix webinar. Arrivederci.